This is a general disclaimer. Redlands Community College attempts to have the most accurate and up-to-date information listed in its content and delivery. However, your education is your responsibility. Redlands Community College or Roy Smith makes no guarantee in the accuracy of this information in this video and accepts no liability for the informational video. The information expressed is strictly the opinion of the author and the presenter, which is listed in the reference near the end of the video. This information is designed to supplement your own education or initial education and should not be used to replace any current academic program you're enrolled in. View the information and content at your own risk. Thank you. Okay, this is going to be asystole. And areas we're going to cover here are going to be pathophysiology. We're going to do a quick pharmacology review. We're going to talk about how to actually treat it. And then we're going to go over a scenario here. So whenever you take a look at this or you see this on the monitor, you pretty much discover that there's no electrical activity, and that's what this nice flat line down here means, is the heart does not have the ability to generate electrical activity. This transfers to there's no cardiac output, and the patient is probably pulseless in this rhythm. There are multiple causes of asystole. It is one of our causative rhythms. PEA is another one. But as we talk about these, the ones that have an M on them here are mechanical, which means that you might, if you see it in the presence or with PEA, you might actually get a narrow complex rhythm that looks like it would probably generate a blood pressure and a pulse quite well. But we have hypovolemia, which is obviously if you bleed all the way out and don't have any cardiac output, that pretty eventually it will become nice and flat. Next one is hypoxia. Without oxygen, the myocardium just does not function. And this one is hydrogen ion or acidosis. This one is if you live at a pH of 7.35 to 7.45. If you're out by 1 point in either direction, it's not healthy. It's an environment that the physiology cannot function in. Hypo or hyperkalemia, this refers back to the sodium-potassium pump. That you have to have appropriate amounts of ion, potassium ion, in and outside of the cell for the sodium-potassium pump to actually function. And then we have hypothermia, which is pretty much cold. If you are frozen, things will eventually slow down and go away, and that's what hypothermia is. Next one on here is tension pneumothorax, and this is a mechanical cause. Example of this is the lungs deflate. You have an open sucking chest wound here, and essentially this lung will get smaller and smaller and deflate. And what happens is that this will cause pressure to increase on this side and cause a mediastinal shift. Now this collapses all four chambers of the heart. If you catch this quite early and the patient is in PEA, it'll look like it's going to make an awesome cardiac output. And then cardiac tamponade. You have a sac that surrounds the myocardium. You bleeding in between here and the myocardium would cause the heart to collapse. The four chambers, once they collapse, decreases ejection fraction, which transfers into lowering cardiac output. In a PEA, this might also be a narrow complex and look like it should be producing an awesome cardiac output. Toxins, overdoses, beta blockers would be on this list, reducing cardiac output until finally everything goes away. Tricyclic antidepressants would be on this list. They're acid by nature. Antidote would be sodium bicarbonate. Thrombosis or pulmonary thrombosis. If you get a clot that occludes the pulmonary artery, no more blood gets circulated through the pulmonary trunk. And then coronary thrombosis, if you have a heart attack and you've had a global MI and your ventricles essentially are dead or dying, they may not have the ability to generate electrical activity and or cardiac output. So these are reversible causes. If we can get ahead of any of this, we can actually probably do pretty good. Example of this. I'm going to erase some of this so it's not so busy. If you can get ahead of the hypoxia, you've caused the underlying event that has got them there to begin with, the patient probably will have a better outcome or do pretty well. If you correct hypovolemia by giving them a fluid bolus, so let's just write out here what these are. Fluid bolus would be the fix for this. And obviously stop the bleed. They got them there to begin with. Hypoxia, oxygen. Hydrogen ion, and this is going to be bicarb. This is going to be our answer for that. Hypokalemia, for the hypo, it's going to be potassium. For the hyper, something a little different, which would be calcium chloride. And it doesn't really do anything for the hyperkalemia, but it allows the heart to function in a hyperkalemic environment. Hypothermia, warm them up. Tension pneumothorax, restore interthoracic pressure. And what I mean by that is decompress their chest or throw in a chest tube. So chest decompress. Or chest tube. Cardiac tamponade would be a pericardial centesis. Toxins, the answer on this is to get ahead of the poison that's actually causing this. Example, tricyclic antidepressant, antidote for that would be sodium bicarbonate. For a beta blocker, antidote for that would be glucagon. And then probably an epidrip. Pulmonary thrombosis. If you're in a spot to where they can actually perform chest surgery and get this out or thrombolize this, the patient has a pretty good chance. If you find them acutely, the patient doesn't have a good chance, especially if it's complete. So this is going to depend on the severity and how fast you can actually get them to critical intervention. Coronary thrombosis. This is the same thing. Percutaneous transluminal angioplasty, or PCTA, or cath lab, a cabbage, or actually fibrinolysis through TPA. And those are how to get ahead of the reversible causes. Pharmacology review, we're going to review epinephrine and sodium bicarbonate. And the early out here is if you are going to use it, please use it in an early fashion. Epinephrine mechanism of action is pretty much a synthetic catecholamine, so it works directly on the alpha and the beta receptor sites. And our primary indication for this is going to be in a pulseless arrest. I know, and we use it for anaphylaxis too, but primarily in ACLS is going to be a pulseless arrest. The adult dose of this is going to be 1 milligram every 3 to 5 minutes, so there's actually a clock whenever we start to deliver this. Absolute contraindication, and that's going to be none in the areas above. And the areas above, what we're talking about here is a pulseless arrest. Vasopressin is on our list too. This acts like ADH, and what this vasopressin does is antidiuretic hormone. It would essentially squeeze out what remaining catecholamine that you would have stored in your adrenal glands. Now, what this does is this gives us not only a V1 receptor, which is a vasoconstriction, but it also makes available our catecholamine stores. It is an alternate to epinephrine, but we can only use it in the first 10 minutes, and that's because after that, they're probably out of those catecholamine stores. The adult dose for this is 40 units, and it's a one-time dose. And the absolute contraindication for this is going to be pretty much a hypersensitivity to the drug class, or if they've had this before and it's given them major hives, we probably wouldn't want to give it to them again. Last but not least is sodium bicarbonate. This is a blood alkalizer, and what this does is this alkalizes things. Bicarbonate is this, And what this does essentially is this picks up extra hydrogen ion. Oh, my apologies, that has no negative on it. And it makes carbonic acid, and that's what this is. And by doing this, what you get is you get a storage place for the hydrogen ion concentration. Now, on our red blood cell, we have an enzyme that's called carbonic anhydrase, and it will easily break this down to where it's eliminatable in the body, which it will break it down into H2O and CO2. This is also a reversible reaction, so if you're alkalotic and needs to switch it the other way, it can do so. The adult dose on this is 1 milliequivalent per kilogram. A 100 kilogram patient would take 2 amps. They are 50 milliequivalents per amp. And then the absolute contraindication on this is going to be renal failure. If you think that your patient, however, is in an acidic state, even if they're in renal failure, they're going to need dialysis at some point. So the point of this is you may utilize the sodium bicarbonate and then worry about the post effects later on. Treatment algorithm for asystole, we're going to start CPR, give oxygen attached monitor, and we're going to do this in a CAB format. Compressions, airway, and then breathing. This is new BLS change in 2010. We're going to run a quick assessment on them and see if they're responsive and if they have any chest rise. If not, we're going to initiate chest compressions. And then we're going to worry about the airway and breathing. While we're in a CAB state, we're going to do 30:2 compression to ventilation ratio. We're going to do this in 2-minute cycles and check for a pulse in between there, not stopping our chest compressions for more than 10 seconds. At the point that we get the CPR kicked off, we need to perform some sort of ALS bridge. And an example of this is to initiate an IV or IO and then consider some type of advanced airway. As soon as we get the med route on board, or the ability to push a med, we should initiate and push epinephrine. This is our treatment and our only drug that we're going to give in this treatment algorithm. Once we get that on board in the advanced airway, we should start trying to get ahead of any possible reversible cause, and these are the H's and T's. Examples of these are what we went over earlier: hypovolemia, hypoxia, hydrogen ion, hypo and hyperkalemia, hypothermia, tension pneumothorax, cardiac tamponade, toxin of any sort, PE, a pulmonary thrombosis, or an MI, big gigantic global MI. So these are our reversible causes, and some of them, as we addressed earlier, have specific treatment modalities. Fluid bolus for the hypovolemia, oxygenation for the hypoxia, sodium bicarbonate for the hydrogen ion acidosis, either potassium or calcium chloride for hypo or hyperkalemia, hypothermia, rewarm them, tension pneumothorax, reinflate the lung, whether that be needle decompression or chest tube. Cardiac tamponade, pericardial centesis, toxins, we need to figure out what it is and get ahead of it with an antidote. Pulmonary thrombosis, if they're in the right spot, we can go in there and we can thrombolize that section. If not, it's going to be pretty dire. And then coronary thrombosis, again, if they're in full arrest at this point, and we can actually get an ROSC and get them to a place to where they can reperfuse the myocardium, that's the direction that we would like to go. So here is scenario section, and the scenario will follow this. You have a 65-year-old male found by a postal worker at home. The patient was found supine on the floor. Patient is still warm to touch, no lividity or rigor, unresponsive and no breathing, no pulses, and shows this on the monitor.
Start CAB 30:2 and compressions at 100 per minute. Obtain a sample OPQRST history. Start preparation for intubation, IV or IO. Finish the 2-minute cycle, if currently is what is shown on the monitor. This is a non-shockable rhythm. Perform a pulse check no longer than 10 seconds and resume chest compressions. Start assessing for the H's and T's or Chat4HDOA. Intubate and confirm tube placement. Establish an IV or IO. Administer epinephrine 1 milligram every 3 to 5 minutes. Reassess for return of spontaneous circulation every 2 minutes. And transport the patient.